All right. Hey, guys. Why don't we go ahead and get started? First and foremost, I hope everyone's been staying safe and doing well. And thank you all for joining today. Why don't we go ahead and get started with some introductions? Andrea King, I believe, would you like to start for us?
Hi, I'm Andrea King. I'm a nurse practitioner at the Fairmont Clinic MBA in Fairmont.
Perfect. Thank you. And Nell Stewart, would you like to introduce yourself?
This is Nell Stewart, and I work for Marshall University as a rural health coordinator.
Perfect. Thank you. Dr. Rexroad, would you like to introduce yourself?
I'm Carmen Rexroad, family physician at Pendleton Community Care in Franklin, West Virginia.
Thank you. And Caitlin?
Hey everybody, I'm Caitlin Ettinger with Project Echo.
Thank you. And everyone over at the Endocrine Hub with Nadia.
Hi, I'm Nadia Barghouthi. I'm an endocrine fellow here at WVU in Morgantown.
And I'm Jessica Perini, one of the endocrinologists here.
Perfect, thank you. We have a Tanya. Would you like to introduce yourself? We see you hopped on.
Hi, can you hear me?
Yes.
Wonderful. I'm sorry, I'm trying to get untangled here and get
no worries at all.
settled in. I'm Tanya Vanatter, and I'm behavioral health with Cabin Creek Health Systems.
All right, perfect. Thank you so much for joining. So why don't we go ahead and get started? Nadia, I can pull up your didactic for you and advance the slides for you. Just say next slide and we'll go. So let me pull it up. Okay. And anytime you're ready, the floor is yours.
All right, guys, so today I'm going to talk about hypercalcemia and hyperparathyroidism, and it's just kind of an overview about what to do, what labs to get, who needs treatment for what. So you can advance. So this is just the algorithm on UpToDate. I'm not going to go through the whole thing. I just wanted you guys to know that it was there, and it distinguishes basically if the hypercalcemia is due to parathyroid hormone or if it's parathyroid hormone independent, PTH independent. But we're going to go through kind of the steps, and they're all here in one little chart. You can advance. So the first question is, so what do you do if you have an elevated calcium level that you just get on routine labs on, in the primary care clinic? So the first step is you get an albumin level to confirm that the patient actually has high calcium level. So 40 to 45% of calcium is bound to albumin. And if you have a low albumin, the calcium will correct up. And if you have a high albumin, the calcium will correct down. So the actual calculation is right there. The corrected calcium is the serum calcium plus 0.8 times 4 minus the patient's albumin level. You can also find these calculations on like MedCalc or any like apps that you might have. So I just put an example here. So a calcium level of 10.4, you see that on their labs. You get an albumin level, it's higher at 4.6. So it corrects down to 9.9. So it's actually a normal calcium level. So step 2. So say you have a corrected calcium and it's actually a little bit high, about 10.3 to 10.6. So then the next step is just instruct the patient to hydrate, and you repeat the calcium with an albumin level. And there's a lot of causes of dehydration, and that can cause a pseudo hypercalcemia, and it's usually very mild hypercalcemia. And you might see like an elevated BUN or creatinine, mild AKI, and they'll be like on diuretics, or they'll be complaining of frequent urination, diarrhea, that kind of stuff. And next slide, please. So now that you have 2 confirmed elevated corrected calcium levels, now you need to determine, is it PTH mediated or PTH independent, meaning coming from something else that's not the parathyroid glands. So you just get a parathyroid hormone level. So if the parathyroid hormone level is high, or even if it's high normal, then it's likely PTH mediated. And if it's low or low normal, then it's likely PTH independent. Next slide. So the PTH mediated causes of hypercalcemia are pretty much there's three. So primary hyperparathyroidism is the most common cause. That could be from an adenoma or parathyroid hyperplasia from multiple glands, or rarely a parathyroid carcinoma. A disease called FHH, which is familial hypocalciuric hypercalcemia, which is a benign disease. It's genetic and doesn't need treatment. We'll talk about that in a little bit. And then tertiary hyperparathyroidism is pretty much primary hyperparathyroidism that's really severe. It's usually seen in end-stage renal disease patients. It's pretty much where they've had hyperparathyroidism from their renal disease for such a long time that the parathyroid glands they develop hyperplasia, and then they just keep producing parathyroid hormone. So if the patient had normal calcium levels any time in their life, like you look back at their labs and they've been normal before, then it's really unlikely that it's FHH and more likely that it's primary hyperpara. If their calcium is really high, then it's more likely to be primary hyperpara. And if it's associated with any symptoms like kidney stones, bone disease, confusion, abdominal pain, that kind of stuff, then it's more likely to be primary hyperpara as well. Next slide. So if they don't have a history of normal calcium levels, or if you don't have any access to any prior labs, so the way to distinguish FHH from primary hyperparathyroidism is you get a 24-hour urine calcium and creatinine level. And that's to calculate something called a calcium creatinine clearance ratio. And that's the equation right there. Usually less than 0.01 is FHH, and usually more than 0.02 is primary hyperpara, but there can be some overlap. But before you get a urine collection, you have to rule out stuff that can cause low urine calcium with a high PTH, and that can mess up the collection results. So vitamin D deficiency is usually a big cause. So you just get a 25 vitamin D level and you supplement as needed. If they have a calcium deficiency, like a very low calcium diet, for example, so just kind of ask them about dairy intake, that kind of stuff. If they take calcium supplements, and then you can supplement as needed. If they have mild renal insufficiency, they can have an inadequate urine collection, or if they use diuretic like hydrochlorothiazide or lithium. Next one. So for FHH, it's an inactivating mutation in the calcium sensing receptors. So it pretty much just makes it where you need a higher calcium concentration to suppress parathyroid hormone release, so it just alters the calcium sensing set point. It's a genetic test to confirm, and you don't need to do anything for it. Next slide. For primary hyperparathyroidism, so this is a lab diagnosis, and we tell our patients that, when we get imaging, that it's just to help the surgeons localize which of the parathyroid glands are overproducing parathyroid hormone. So if you have a negative image, it doesn't mean you don't have primary hyperpara, it just means that the scan was negative. So the indications for treating primary hyperpara are if they're less than 50 years old, if they have kidney disease, so a GFR less than 60, or if they have kidney stones. And these can even be asymptomatic, like if you see them on a KUV x-ray or a renal ultrasound. If they have osteoporosis, and this includes osteopenia with high FRAX scores, and if they have a corrected calcium level 1 above the upper limit of normal. And they only have to have one of these to qualify. They don't have to have all of them. And then for imaging, to help localize, if you think that they're going to be a surgical candidate, you can get a thyroid ultrasound and a nuclear parathyroid scan. That's the sestamibi scan. And then about, just note, 25% of sestamibi scans don't light up. And then the surgeons can either order a CT parathyroid protocol, or if needed, they can do parathyroid exploration and kind of just look in the neck, and they can tell like which one looks plumpy and take that one out. Next slide. So for treatment for primary hyperpara, so the preferred treatment is surgery because it's a cure and it helps osteoporosis. But if they're elderly or they have multiple comorbidities or short life expectancy, they're not going to be a good surgical candidate. You can treat medically with a medicine called Hypercalcemia. The brand name is Sensipar. So it increases sensitivity of the calcium sensing receptor on the parathyroid glands. So the PTH can go down a little bit, and then it lowers the calcium levels. And when you're monitoring patients on Sensipar, you don't really need to keep checking the PTH. You can just check the calcium levels and go from there to adjust the doses. For vitamin and calcium replacement, so deficiencies of either one of those can worsen hyperparathyroidism. So we don't recommend a low calcium diet, just a normal calcium diet, 1,000 to 1,200 milligrams per day. And that can just be in their, their diet. And if they need like a supplement, that's fine, but usually you don't need to give a supplement with the hyperpara patients. And then for vitamin D supplement, you can give them 1,000 to 2,000 units a day, for example, if the 25 vitamin D is less than 30. And then if they're treated medically with Sensipar, so like I said above, it doesn't help osteoporosis, so you should also treat osteoporosis with the proper medications. And I listed the just examples of medications to treat osteoporosis, but you shouldn't use the PTH analogs, which are Forteo, which is teriparatide, and abaloparatide Tymlos in hyperparathyroidism. Next slide. So for the PTH independent hypercalcemia, so this is hypercalcemia not from the parathyroid gland, it's from something else that's suppressing the parathyroid gland parathyroid hormone production. So you should check a 25 vitamin D and vitamin A levels to rule out excess of either one of those vitamins. A TSH, because hyperthyroidism can cause PTH-independent hypercalcemia. The most likely cause of PTH-independent hypercalcemia is usually malignancy. So the different kinds of workups for that are an SPEP, UPEP, and kappa lambda free light chains for multiple myeloma. 125 vitamin D, which is calcitriol, to evaluate for granulomatous diseases like sarcoid, TB, lymphoma, some of like the weirder infections like histoplasmosis, coccidio, that kind of stuff. A PTH-RP level to look for humoral hypercalcemia malignancy. And then looking for bone mass. So just, based on history, are they having like severe hip pain, skeletal pain of some kind? You can get a CT scan or skeletal survey. You should do a calcium intake history to see like, are they popping like tons of Tums or eating excess yogurt all the time? Or are they on tube feeds or TPN with a lot of calcium supplementation in it? If they're immobilized. And then some medications that can cause hypercalcemia, hydrochlorothiazide. It enhances active calcium resorption in the distal tubule. And then the PTH analog osteoporosis medications can also cause a PTH-independent hypercalcemia. It's not that common, but it can happen. Next slide. I don't know if you guys deal with this, but I just put a slide about inpatient hypercalcemia treatment. Basically, you just start with fluids, isotonic saline, and then you can give them calcitonin. That'll be short acting. You usually only give up to 4 doses because it stops working after that. If renal function is okay, you give a bisphosphonate. Usually in the inpatient setting, it's zoledronic acid or permethrinate. If they're getting fluid overloaded, you can give Lasix in addition to the fluids. Steroids, if it's a calcitriol-mediated hypercalcemia like the sarcoid or lymphoma. If they have poor kidney function, you can give denosumab. And then if they have PTH dependent, so primary hyperpara, that's the calcimimetics is the Sensipar. And then if you really need rapid treatment, severe hypercalcemia, not responding, you do dialysis. Next slide. So this is just to see, like, I've noticed some providers just get a PTH level, and I'm not sure why, but some people have just been drawing them. So what do you do if you get a patient and they just happen to have an elevated PTH level? So first thing is get a BMP with an albumin to see if they actually have what their calcium is, pretty much. And so if the corrected calcium is normal, then it's likely a secondary hyperparathyroidism. This is usually from CKD, usually about stage 3 CKDs when you start to see it, or more likely vitamin D or calcium deficiency. So you would get a 25 vitamin D level and replace that. The dietary calcium history, you can add Citracal or Tums or some kind of calcium supplement if they don't eat any dairy products or you feel like they're deficient. If needed, you can get a 24-hour urine calcium with creatinine to look for a calcium deficiency. And just a little note that if the urine calcium is high, there's something called idiopathic hypercalcemia that you can treat with either hydrochlorothiazide or chlorthalidone is the preferred. If they have persistently low vitamin D and you're giving them like 50,000 units weekly for weeks on end and they're not improving, you need to start thinking about, is there some malabsorption going on, celiac disease, pancreatic insufficiency from like cystic fibrosis, chronic pancreatitis, that they might need prion supplements, something like that. And then if they have CKD, you can refer to nephrology. They usually treat them with calcitriol to bring the PTH down if needed. And then if the corrected calcium is high, it's either primary hyperpara, or if they have really bad kidneys, tertiary hyperpara. Next slide. That's it. Any questions or cases that anyone wants to talk about?
Thank you so much, Nadia. That was excellent.
Oh, no problem.
Yeah, we'll open the floor for any questions or comments for Nadia or the group as a whole.
I'll make a comment about the secondary hyperpara in the last slide or two, where she was talking about if you just happen to randomly check a PTH level and it's elevated, but the calcium's normal. If you do find that their vitamin D level is low and you work to correct it, it can take at least 3 months before you would start to see the PTH levels coming down towards normal. And just seeing that they're kind of moving towards normal is very reassuring, and it doesn't really need to continue to be monitored over time. We really don't care what the PTH level is if the calcium's normal and the vitamin D levels are normal. It's really just doing its job if it goes up in response to renal losses or vitamin D deficiency. It in and of itself is not really something that we use as a marker of anything in particular. So it doesn't have to be followed or chased too much.
Can I ask? I'm sorry, I'm a little naive to this. I don't see patients. I'm not a clinician. What would these people present with? What symptoms that you would even go to check?
So most of the time, the basic metabolic panel is just a lab that many providers just get to monitor kidney function and electrolytes, and the calcium is part of that.
Yeah.
But if they were having symptomatic hypercalcemia, usually they present, especially if it's severe hypercalcemia, they can present with confusion, really dehydrated, like their skin will look, dry, and they can have constipation, belly pain. Some people describe like bone pain, like in the long bones, not just like joint arthritis type of pain, that kind of stuff.
Great, thank you.
I was also just going to ask if there any benefits to parathyroid surgery and when you would recommend that measure?
Yeah, so in primary hyperparathyroidism, I had talked about the qualifications for parathyroid surgery, where if the calcium is 1 above the upper limit of normal, if they're young, less than 50, cirrhosis, or if their kidney function is impaired, those people benefit from surgery if they're a candidate from it. Also, if they have osteoporosis, the surgery will help osteoporosis, but the medication won't. So that would be something. For tertiary hyperparathyroidism, which is the pretty much like vamped up primary hyperpara that we see in the end-stage renal patients, their cure is usually surgery.
Thank you.
Sure.
Any other comments or questions? Feel free to chat us on the side as well, and I can ask for you if you'd like.
How do I see chat things?
This might be sort of an interesting question, but you kind of touched upon if you have elevated parathyroid hormone and but the normal calcium levels, how would your daily diet or your diet over time affect that? Is that something that is usually addressed as well, calcium intake through your diet?
So usually if you have a calcium deficiency, your body's gonna try and hold on to as much as it can. So the serum calcium will likely look normal in a calcium deficiency, but the urine calcium will be low and will be, so that's where we would get the 24-hour urine calcium to check, but also just like asking them about their dairy intake, if they eat cheese or milk or take calcium supplements, that usually kind of gives you an idea if they might not be taking in enough calcium.
Also, people who've had gastric bypass surgery, they're kind of chronically on the edge in terms of malnutrition. So you'll often see high PTH levels in those patients, partly because of a chronic almost deficiency of calcium or chronic almost deficiency of vitamin D. And so PTH levels are often high in those people as a secondary reaction to the low D or calcium. And again, those people are on very particular regimens for how much vitamin D they should be getting, ways to get calcium as, you know, different sources of calcium for their normal diet. And so those people would have the low normal calcium, but it should still be normal.
I see, thank you. Anything else from anyone? Maybe if you've had patients with similar symptoms or signs. Thank you so much, Nadia, for that.
No problem. Thank you for having me.
Yeah.
Thank you.
Yeah, no, I was just going to say that's excellent. I really appreciate it. I could go on more and more about different questions that I have, you know, so if there are any further questions for Nadia or anything regarding her didactic, feel free to shoot me an email as well. I can send them over to her and make sure they're answered for you. Anything from the Endo Hub you guys all want to maybe talk about? We do still have about 30 minutes left, so there's a lot open for discussion.
All right. Thank you, guys.
Thank you. I do have one quick update and announcement. So our next session is on April 8th, and Jessica Perry will be providing our didactic on goiter management. So keep an eye out for that. And just a quick plug, tomorrow at our Hep C session, we are going to have a discussion on COVID-19. So feel free to join that, bring any questions you may have. And if you didn't get an email with the link to join or have more questions for me, just shoot me an email. I'll make sure you have all the information to attend that. But thank you so much, everyone. Thank you so much, Nadia, and we'll see you guys next time.
Thank you. Bye, guys.
Thank you. Bye.